Doctors, what is the most unethical thing you've done or have heard of a fellow doctor doing involving a patient? I once knew an OB who didn't like to work after about 5 p.m., so at the end of office hours, if they had someone in labor, they would swing by labor and delivery and find a reason to do a C-section on them. Sometimes they blamed the baby's heart rate tracing, justified or not, but the classic one would be that they would check the patient's cervix and lie about how dilated it was, so it seemed as if labor wasn't progressing rapidly enough. They would just say, "I just don't think this is going to work," cut her, and be home for dinner. Now in OB, we love TLAs, 3-letter acronyms, and one of the real indications for cesarean is CPD, cephalopelvic disproportion, which is where the baby's head is too big for the pelvis. But for this particular doc, we always said that they cut patients for CPD, cesarean prior to dinner. Edit. No, I didn't report this doc because it's not possible to report someone for a subjective judgment call. As for this doc not being allowed to practice anymore, a hospital can't revoke privileges for being a crappy doc even if they want to. The law is written in such a way that the hospital would easily be sued for restraint of trade. I don't like it either, but unless the laws get changed, that's what we're stuck with. This thread scares me. I really hope this is sort of the extent of what we hear, but I know it's not going to be. Come on, man, I don't need any less faith in the medical system than I already have. Story 2. Not unethical exactly, but frowned upon by the hospital if they found out. When I was a junior doctor, I had an elderly patient on our specialist cardiology ward who'd had to travel 100 miles for a really specialist treatment. She didn't have any family, and all her friends were similarly elderly and couldn't drive far, let alone a 200-mile round trip to visit her. She confided in me that she was running out of clean night dresses and was embarrassed as she didn't know what to do. So I took them home and washed them for her in my machine. Looking back, I'm sure there was some procedure I should have followed. We're not supposed to get personally involved, but she was so sweet. It was late and all the admin people had gone home. Story 3. This happened a few years ago and began when I was a third-year medical student during my general surgery clerkship. Just to get my bias out of the way, I should say I really did not like the surgeons charged with running the clerkship. I thought they were incredibly unprofessional, egocentric jerks who only cared about how much a student would kiss their butt. And this went far beyond the stereotype of the typical surgeon. I shadowed surgeons in high school and college and always wanted to be one, but this department was dysfunctional on a level I had never encountered before or since. I could write a book of the insanity I witnessed there. So anyway, this particular incident starts about a month into the clerkship. By now, us med students had settled into our roles there, learned the daily ins and outs. Get there around 5:30 a.m., have morning conference and rounds, spend the remainder of the day in the OR or in clinic hours, and get done anywhere between 4 to 6 p.m. on a good day. Once or twice a week we would also do call, where after the regular hours concluded we would report to the ER and work there until around 11 to midnight. So as per usual, I get through the day and arrive at the ER around the usual time. When I get there, the attending covering the ER greets me and gives me a rundown of the patients currently there. Most of them are the usual bullcrap type stuff we see at the ER. Abscesses, a laceration that needs stitches, nothing serious. But he says they have an interesting patient that was just brought in. A woman in her early 70s was just brought in by an ambulance, or actually a second ambulance. She had gone to her GP complaining of dizziness, and the GP sent her to the hospital. The GP was concerned about her driving in her state, so they called her an ambulance to drive her to the hospital. On the way to the hospital, the ambulance got into a car accident and flipped on its side. So the woman was then picked up by a second ambulance and brought to the hospital. Now, in addition to getting a workup for the dizziness, there was concern of internal injuries stemming from the car accident. So she gets a CT, and afterwards gets parked in the urgent room of the ER. The ER is divided into surgical and internal sections, and on the surgical side there's a bay room where the more urgent cases get brought for triage care. Stabbings, gunshots, serious car accidents. The room has a couple of dedicated nurses, whereas the other 3 surgical ER bays share a group of nurses. The patient is hooked up to every monitor and then some, but she is awake and seemingly in good spirits. I apologize for the detail here, but I want to paint a vivid picture of how incredibly screwed up what happened really was. So at this point, I go over and introduce myself. Let her know I'm the student doctor on the floor for the evening, and if she needs anything, my name is my name, and to just ask. I'll call her Mrs. X at this point for ease. A little bit later on, we get the CT with the radiologist's report, says there's no internal injuries noted and no bleeding. The attending reviews the CT and report, as does the resident, and things seem to be fine. The night goes on. I follow around the resident doing the crap work for the night, mainly cleaning up after he drained a couple of anorectal abscesses, like clockwork. Every time it was my night in the ER, it was as if the moon and stars aligned to obstruct the anal sinuses of many a citizen and send them to my doorstep. But that's not part of the story. Okay, so I get through the night, periodically checking up on Mrs. X in between my other tasks. And at around 11 p.m., the attending says it's pretty slow, so I can call it a night. I say goodbye to the staff, say goodnight to Mrs. X, and that I will see her in the morning. So I go home and crash. Get up the next day and head in around 5:30 for the regular morning meeting that comes before rounds. When I arrive, I could immediately sense that something was off in the room. Everyone was visibly on edge and quiet, not even whispering among themselves. They were waiting for the department head to arrive and kick off the meeting. So the department head arrives and he looks very unhappy. You should note that this man always looks unhappy. He was a German Jewish fellow in his late 60s and he was tough as nails. Always serious, never a smile, and never a compliment. You know, in those World War II movies where they portray the Nazi villain as just some caricature of stern seriousness that is incapable of emotion? That was this guy. Some of the residents even had a couple of Nazi-inspired nicknames for him, which, me being Jewish, I found funny. But again, not the point. He walked into the room without saying a word and sits at the head of the table. There are now 30-plus people in the room, mostly attending physicians, residents, and med students. About 30 seconds pass without him saying a word, and then he lets loose. In the span of a few seconds, it was just a torrent of hate and vitriol pouring out of his mouth. His face turned so bright red I thought he was going to ignite his hair. He was talking really fast and was so angry it took a couple of moments to piece together what exactly happened. At around 1 to 2 in the morning, Mrs. X started having trouble staying conscious. She was rushed to the ICU, and at the time of the meeting, she was in a coma with a very low likelihood of recovering. Apparently, the radiologist, attending, and resident all missed what was allegedly, at the time I was not particularly skilled at reading CTs, a very obvious lacerated spleen. And to make matters much worse, the resident on call wrote in her chart ordering 24-hour observation. To the uninitiated, that may seem normal, or at the very least, not problematic. However, in this setting, when you want someone observed, you need to give clear instructions on exactly what you want observed and at what time intervals. Writing to have the urine output checked every 15 minutes, or blood pressure or oxygen saturation, or any number of other parameters to assess the status of the patient. These things need to be very clearly enumerated to ensure the patient doesn't get overlooked. And unfortunately, that is what happened to Mrs. X in this case. Without instructions for what to do, the medical staff, attending resident nurses, all just sort of passed by her, assuming someone else was on it, or assuming that since there were not clear instructions, everything was all right. So the verbal reaming continued for what felt like hours. The resident that wrote 24-hour observation got told several times by the department head that she would be thrown out of the program during his scream session, and this was in front of the entire department staff. The attending on call got it just as bad, if not worse. Unprofessional, lazy, not worthy of being a doctor, pretty much anything you can imagine. During his tongue lashing, it was implied that he should start sending out resumes to other hospitals. Finally, Herr Doctor decides to end his scream session by rhetorically asking the doctors involved what they plan to tell the family of Mrs. X, to which they all sat silently. After a moment of awkward silence, everyone starts to shuffle out of the room and continue on with their day. So now fast forward a couple of months. At this point, I have finished my surgical clerkship and a couple of clerkships that followed it. Now I'm rotating through a family medicine clinic in the suburbs about a half hour from the hospital. On this particular day, we get an elderly gentleman coming in complaining of a cough or a cold. I can't quite remember what his original complaint was. Anyway, the doctor I'm working under, let's call him Mike, says that this patient, Mr. X, is an interesting story. Dr. Mike says that a couple of months earlier, Mr. X's wife came in complaining of dizziness, and he sent her to the hospital to get a more thorough workup. Mr. X then tells me what happened to his wife, as he was told by her doctors at the hospital, a surgeon from the department I clerked at. It was said that on her way to the hospital, the first ambulance ran a red light, and in the ensuing accident, she suffered an internal injury. After she passed, they told him there was nothing they could do, that they did everything they could, and that she ultimately succumbed to her injuries. When he was telling me this, he was getting a bit irate, because he said he was with her late that night in the ER. This would be prior to being rushed to the ICU. He had been trying to get the attention of a doctor or nurse to no avail for a couple of hours because he thought she was worsening. So, with little recourse left and being told that it was the ambulance driver's fault, he was currently pursuing legal action against them. I remember him telling me his story so vividly because I was overcome with anger during the whole thing. First, being reminded of such a stupid screw-up by so many people that ultimately led to Mrs. X's untimely death, and then infinitely more angry when it became clear how much he had been lied to or intentionally misled concerning his wife. And I vividly remember how not at all conflicted I felt when I told him everything I knew about the situation. That I was on call when she arrived to the ER, that I spoke with her throughout the early evening, that multiple doctors missed the lacerated spleen in her imaging, about the resident's screw-up in the chart that escaped notice of the attending and led to his wife being basically ignored until she was comatose, and about the conference the following morning where it was clear that everyone in the department knew what ultimately caused Mrs. X to die, and that he was clearly being lied to by whomever he spoke with. I remember the look on Dr. Mike's face, almost a look of shock and happiness. Dr. Mike and I had really hit it off from the start of my family medicine rotation. Even though I didn't go into family med, I really loved the community work. Also, Dr. Mike and I had very similar philosophies about medicine and life in general, so we got along really well. And I could see he was happy that I decided to speak up and tell the truth about what happened, instead of keeping quiet to protect a fellow doctor. It was at that point, of course, that I remembered, crap, I'm still a med student, and I just outed what could be at the minimum a serious lawsuit, and at worst a scandal at the primary hospital of the medical school I attend. I could face very serious retaliation over this. I don't want you to think I'm exaggerating. There was a fellow student who admittedly was a real jerk that no one liked, who spoke up about some shady stuff the administration was doing a year earlier, and he got expelled from the program over it. Fortunately for me, Mr. X was extremely mindful of my situation, and he and Dr. Mike told me they would keep my name out of anything that happened going forward. To this day, I still keep in touch with Dr. Mike periodically to see how things are going. Last I heard about Mr. X was a couple of years ago. He had his lawyer go after the doctors responsible and the Department of Surgery. Knowing this was a case of egregious medical error, the hospital offered to settle, and because they were now aware that the doctors actually lied to them and tried to cover up their error, Mr. X got a settlement almost an order of magnitude larger than he would have had it been just an egregious error minus the lying. I know, of course, that doesn't make up for Mrs. X. And frankly, I wish he hadn't settled but taken them to court and tried to have the medical licenses for all those involved stripped. But Mr. X did what he needed to for him and his family to move on from their tragedy. I'm only glad I could play a part in making sure those scumbags that give my profession a bad name paid for their callous disregard of their moral, ethical, and legal obligations. And that is my story of the most unethical thing I have ever seen another doctor do involving a patient. Alright guys, a little breather. Whew, that was a long one. But also, probably one of the best answers you could get for this kind of question. This is a very real scenario that I can guarantee has happened more than once. I think it's an insanely bold move that OP did to just out what actually happened. And huge of Mr. X and the doctor to leave OP's name out of it because, yeah, that could destroy him. There were a few people on the right side of history here, so good for them. For everyone who lied to Mr. X, I hope they got what was coming to them. That's all I'll say about that. And I understand mistakes happen. It's not about the mistakes. It's about lying about the mistakes. You gotta own up to these things, especially when life is involved. Story 4. I briefly worked as the front desk clerk for an ER at a local hospital. The rule was that anyone who came in complaining of chest pains had to be back and on a machine within 10 minutes of arrival. Once I entered their name into the system, a clock started. So I was told to not enter their name until they had already been taken back to essentially make our numbers look better and make it appear as though they were receiving care within the prescribed 10 minutes. Edit. People complaining of chest pains were typically brought back quickly, just not always within the 10-minute guideline, although faster than anyone else. This mostly seemed to just be about producing better stats, although keeping it off the system gave them the ability to delay. There are 3 kinds of lies in this world: lies, damned lies, and statistics. My opinion, never trust an individual stat. They're almost always manipulated, and if you have chest pain, take aspirin. Story 5. I'm a physician and used to work 12-hour night shifts at this hospital in California. My coworker, who was also a doctor and admittedly a young and good-looking fellow, and I covered pages from different floors. If there was nothing going on, I would usually be in my call room reading, sleeping, watching TV, until a nurse would page me for a problem. My colleague on call's room shared the same wall with mine. One night I was reading in my room when I started hearing my colleague and another woman banging. The noises started getting louder and fairly difficult to ignore. Sorry, she was pretty loud. Then, in the middle of this charade, I heard his pager go off several times without him answering it. Eventually, I left the room and called the hospital operator. I asked her who had paged Doctor, my colleague's name, and then called the nurse who was trying to get in touch with him. Turns out the page was for a patient that was in a very serious condition and had to be taken to the ICU. I took care of everything and went back to my room. Later on, I told him they were paging him for a critically ill patient overhead and that he must have fallen asleep. I didn't say anything about hearing his Allegro chamber banging orchestra, but I think he knew that I knew. He got red and thanked me for covering him. Story 6. I'm a general surgery resident. We had a patient who had been in our service for about a year. Older fellow, very sick. Every now and then he would go into respiratory distress, get intubated or BiPAP for a bit, and always would bounce back to his baseline of 8 out of 10 sick. Everyone called him the Rock, but not in a cool, like, do you smell what the Rock is cooking way? In a boring sick person that sits there way. Well, he had always been a full code. That means that in case of dying, we do everything we can to keep him alive. After a long time of being inpatient, my attending was sick of him and made him a DNRI, which means let him pass if he starts to struggle. He didn't want this, but they got away with it by saying he didn't have capacity. He was decently with it, but I can see the argument. So talks with the family started, and they specifically stated they wanted a full code. My attending didn't agree and decided to call them to confirm, but we think he purposefully called the wrong number many times, and eventually decided for himself he was DNRI. 2 days later, the guy went into respiratory distress and died. I came to rounds the next morning to 2 attendings yelling and screaming about, quote, the right thing to do. Maybe I feel that it's better that he passed as well, but his family's wishes were ignored and purposefully evaded. I could never go against someone's wishes. Nor should you, OP. You have a good head on your shoulders about this thing. Because a patient is annoying, quote-unquote, doesn't mean you get to decide if they should be resuscitated or not. Are you kidding me? Those orders should be given by someone who is very close to or the person themselves. Like, come on, man. Story 7. This happened when I was a medical student working in the ER. This 20-something male was drunk driving and crashed his car into an elderly couple, causing them to require emergent surgery. He was belligerent and walking around naked in the trauma bay. Nurses were trying to get him to calm down and stay in his room and stop yelling. He was calling the nurses female dogs and asking to go to the bathroom, so they gave him a urinal. As he was urinating, my attending went up to him and said, "I want you on that bed right now." He said, "Screw you." So my attending knocked the urinal out of his hand and pee went flying all over the room. He picked him up and threw him on the bed and pushed some rocuronium through his IV to paralyze him. Then he seemed to take his time with intubating him, letting his O2 sat get down into the 40s before finally letting him breathe again. I don't know what ended up happening to the guy in the long run. Turns out he had just broken up with his girlfriend and went on a drinking binge. He deserved to be punished for what he did, but I don't think he deserved to be forcibly intubated for no reason other than causing a scene. Yeah, I don't want that doctor anywhere near someone under mental distress. They seem to have a very short fuse for that sort of thing, which in the medical industry, in my opinion, simply does not fly. I get it. Patients are belligerent, annoying, they're awful to people. Sometimes, yeah, and that sucks. But there are a lot of external factors that you cannot take wholly into account, so you can't be the arbiter of justice here, man. That's bad. Story 8. My mom is a nurse that worked at a hospice. She was known among the other nurses as having a gift. When it was coming time for a patient to reach his or her end, my mom would be able to guess the time of death usually within 5 to 10 minutes. The nurses would make betting pools and really were fascinated by what my mom could do. They would tip her off on a patient in bad condition and she would go in and take their temperature, feel the feet, check their pulse, and walk out with an exact time. She won a lot of money and free lunches in her stay there. When a higher management official approached her one day about it, she immediately started to apologize for her unprofessionalism. The manager stopped her and told her she was in fact impressed by her ability. Story 9. My father is a psychiatric nurse and he will openly say how jaded he is by the incompetent people he works with. He has been employed as a registered nurse since the 1970s, but in recent decades the government has slashed the mental health budget. So instead of hiring qualified nurses who command a higher wage, they hire what are essentially babysitters with no experience. His patients are seriously mentally disabled, not the type who need to be put in a straitjacket, but grown men with the intelligence of 4-year-olds. These babysitters know nothing about restraining them when they get violent. They just cower in the corner and wait for the 1 or 2 nurses in the building. There's also a lot to be said about the character of these babysitters. My dad told me about one patient who had a phobia of cicadas, so this colleague thought it would be funny to catch a cicada and chase the poor patient around the grounds with it. The worst case of incompetence he told me about happened at this hospital that was located within walking distance from a major 6-lane motorway. 2 nurses came in for their night shift. Patients are sleeping, so workers on the night shift will watch TV or do anything else to keep themselves awake during quiet periods. These guys had brought in computer equipment with the intention of repairing or building a computer. I don't know. The fact is, they were so engrossed in their task, they failed to notice a patient who woke up and left the premises. It wasn't until emergency services showed up and told them there had been a fatal accident on the motorway that ended this patient that these nurses realized anything was amiss. Neither of them got sacked, thanks to the strength of the nurses' union. Story 10. Med 4 student here. During one of my internal medicine clerkship in a small hospital, I get paged to a cardiorespiratory arrest in the cath lab. I arrive there and a whole team is already working a way outdated ACLS protocol on a patient that was undergoing PTCA earlier. Apparently, the interventional cardiologist has just placed a stent and was withdrawing when the patient had the arrest. After 40 to 45 minutes of resuscitation, the patient did not pick up, so I was expecting them to just announce the time of death. That's when it gets unethical. The whole staff agreed to just send the patient to CCU, knowing he's dead, intubated on an amp bag, with a monitor showing a nurse's pulse and oximetry. And they were going to tell the patients that the intervention was successful and that he needs observation before being discharged to regular floor. The patient was kept in the CCU and the staff would tell the family gradually he was getting worse. And 2 hours later, they told him that he just died because he couldn't tolerate the procedure. All this to protect the cardiologist, so he keeps a good reputation and record. After I asked around, they were apparently doing this for every arrest that would happen during catheterization at this hospital. Story 11. I'm not a doctor, but I do work at a methadone clinic. I provide services. I had a client that was on 250 milligrams of methadone and continued to use H and benzos regularly, like in the parking lot. He overdosed once in my office and another time in the lobby. We've called the ambulance on this man 4 times. He's been doing H for 28 years. We continued to up his dose and even phased him. He still tested positive for everything. I felt like it was unethical. I'm harm reduction based, but this was insane. It was like we were passing him candy at a parade. We had no idea if he was even taking the methadone. He was most likely selling. The fact that after he overdosed in my office, we didn't encourage him into an inpatient facility was the most unethical thing I've ever experienced. Harm reduction treatment doesn't work for everyone. Story 12. A doctor damn near ended my wife once. She'd been experiencing severe heartburn-like pains for several days, not responding to antacids or proton pump inhibitors. We went to the ER where the doctor insisted I stay in the waiting room, and not only failed to take a history, but actively stopped her from giving one. He took an ECG, which was normal, and bundled her out the door with a spoonful of xylocaine viscous, a script for more PPIs, and instructions to see her GP in a week. A few hours later, she was literally writhing in agony, so I said, "Screw this. took her to a different ER across town. The doctor there actually asked questions and listened to answers. He wheeled out an ultrasound and said, "Whoa," and he booked her for an emergency cholecystectomy on the spot. The op took twice as long as expected. The thing was so swollen they had to drain it for ages before they dared move it. The surgeon later told her that if she had waited for even a few more hours, it most likely would have burst, with hard-to-survive consequences. I don't care about missing a diagnosis. That can happen to anybody. But missing a diagnosis because you will not let your patient give a history? Screw that so hard. I can't even imagine why a doctor wouldn't want to take a history. Does it not just make their job easier? I can't imagine how far up your own butt you'd have to be to not even listen to a patient when they're trying to help you. Yeah, screw you, buddy. And yeah, this thread did make me upset, Joy, but I at least hope you found it entertaining or educational or something. That was the last story though, so for now, thank you so much for watching. I hope you have a wonderful day or night wherever you are, and I will see you in the next one.